Hi, everybody. I'm Mohamad Mohty from Paris in France, and it's really a great pleasure to join you today to give an update about the latest advances in the field of multiple myeloma that were presented during the ASH 2019 meeting in Orlando earlier last week, actually. As a matter of fact, multiple myeloma remains on the podium. The research in this field of myeloma is really moving very fast, very quickly, and obviously it will take us hours and hours to go through all the advances that were presented. So I will focus on a few highlights where I believe they will have a significant impact on our practice in the near future. These are my disclosures, and the presentation outline will address the different topics. I'll start first by summarizing the data related to the treatment of smoldering multiple myeloma, and this is becoming a very hot topic. I'll move later to the management of patients with transplant eligible and transplant ineligible myeloma, then the relapse refractory setting, and I will end up with the exciting field of cellular therapy and immune therapy, especially the advent of bispecific antibodies with T-cell engager. So let me start with the management of patients with smoldering multiple myeloma. This has been the subject of a lot of debates over the last few years, and this has been also rejuvenated very recently thanks to this randomized trial from ECOG comparing lenalidomide versus observation in patients with asymptomatic high-risk smoldering multiple myeloma. These are the patients where we usually don't start treatment immediately. And the key message from this very nice trial is that early treatment with lenalidomide can significantly prevent the progression of multiple myeloma, especially in the high-risk group. So based on these data, many groups started to tackle the issue of smoldering multiple myeloma, and I would divide these approaches into two major groups. One is the so-called, let's say, non-curative approach, relying on gentle therapy, and the goal here is rather to delay the occurrence of the disease, and most importantly, to avoid the organ dysfunction. And during the ASH meeting, we had several studies being presented. I have selected three of them using either daratumumab, anti-CD38, or another antibody, anti-CD38 cetuximab, but also the proteasome, the oral proteasome inhibitor, ixazomib. All of them are phase 2 studies, and the key message is that you are able to achieve a relatively high response rate. However, the rate of MRD negativity in these approaches is relatively low, which further supports the concept of non-curative approach. In contrast, the colleagues from Spain, Mateus and colleagues, have updated their GEM-CESAR study, which one would consider as a sort of a curative approach for smoldering multiple myeloma, because they have identified these patients based on the Mayo or the Spanish model. The patient received strong 6-cycle induction with carfilzomib, lenalidomide, dexamethasone, KRD, followed by high-dose melphalan and auto-transplant, followed by 2 cycles of consolidation and maintenance. And the primary endpoint of this trial was the achievement of MRD negativity. And this is summarized here. So with longer follow-up, actually, during consolidation and maintenance for those patients who were able to go through all these steps, actually, you have more than 60% MRD negativity. So one would speculate that many of these patients, or a significant proportion of these patients, will actually be able to enjoy long-term disease-free survival without manifestations of multiple myeloma. So the field of smoldering multiple myeloma is really now becoming a hot field. The community is still debating, despite the presence of these trials. Some colleagues are still reluctant to the use or to start early therapy in smoldering multiple myeloma. Nevertheless, I think these studies are paving the way for further studies, and this field will move quickly in the next couple of years. Then we go to the management of transplant-eligible multiple myeloma patients, and again, here we had during the ASH 2019 meeting a nice update about the randomized phase 2 GRIFFIN study. And the schema, the design of this study is summarized here. And the key issue is about the use of a quadruplet induction regimen based on daratumumab and VRD, bortezomib, lenalidomide, dexamethasone. So comparing the standard of care VRD versus Dara VRD, followed by transplant, consolidation, and maintenance. And during this update, the authors could confirm the achievement of a high rate of stringent CR, 42% versus 32% in favor of the quadruplet. And most importantly, one could see that the Dara VRD patients are enjoying an almost 99% response rate, which is quite impressive, further supporting the use of such quadruplet regimen, similar to what has been observed with the Cassiope trial testing Dara VTD versus VTD and published earlier this year. And an important message from the update is about the deepening of the response over time. So the more you give, the more patient will go into improved response, and most importantly, MRD negativity. And this will translate into 95% progression-free survival at 2 years and overall survival. Obviously, follow-up is very short. Nevertheless, these survival curves are very appealing and strongly support the introduction of quadruplet induction regimens prior to transplant. The other hot topic that was debated during ASH is the role of MRD in multiple myeloma. There is a growing body of evidence suggesting that those patients with deep MRD negativity are going to enjoy survival, longer survival. And one could speculate that we can use the MRD results to drive or adjust or refine therapy in many patients, as it is being done, for example, in acute lymphoblastic leukemia or with PET scan in lymphoma. And during ASH 2019, we had the first results of the so-called MASTER trial. This is a phase 2 trial, single arm, using a very powerful induction regimen based on daratumumab, carfilzomib, lenalidomide, dexamethasone, followed by autotransplant, followed by consolidation, and other courses of consolidation and len maintenance. And the key message from this trial, or the major feature, is the sequential testing of MRD at different time points during the course of therapy. And those patients who are achieving MRD negativity at any given time point, and if this is confirmed, are able to stop therapy and have a treatment-free observation, which is definitely a wonderful goal to achieve in patients. The idea of therapy discontinuation is an important goal, I think, for quality of life, but also from a pharmacoeconomic perspective. Obviously, this is a single-arm trial. It's not a randomized trial. However, the feasibility is good. And what is really impressive is the more than 80% MRD negativity after consolidation. The threshold for MRD negativity is 10 minus 5. We don't have the data for 10 minus 6, except you can see it here, the colors. It's around 60%. And one would speculate that those patients who are achieving an MRD negativity up to 10 minus 6 are probably able to discontinue therapy. The final confirmation will definitely come from a randomized trial, and hopefully we'll get a final answer to this very important question. And one should not forget that beside biological MRD, the use of PET scan may further support the strategy of evaluating residual disease. And during ASH 2019, we had also communications about the value of PET, especially the Cassiopeatt trial that I'm not showing here for the sake of time. I'll move now to maintenance in transplant-eligible patients. We know that lenalidomide is the standard of care for maintenance after transplant. However, we have seen the results of this LYRA phase 2 trial looking into daratumumab maintenance for 12 cycles. And the key message is about feasibility of such approach, whether in the non-transplant or transplant eligible patients, and again, with a very high rate of response when it comes to stringent CR and CR. And at some point, the goal is to be able to randomize the standard of care lenalidomide maintenance versus lenalidomide plus an antibody, and this is the AURIGA phase 3 study. And you can see the summary of the design of this trial and hopefully we'll get the results in the next few years. I'll move now to the frontline management of patients with transplant-ineligible multiple myeloma. ALCYONE, this is a very well-known study comparing daratumumab VMP versus the classical VMP. And during ASH 2019, we had an update with longer follow-up highlighting almost 30% again of MRD negativity with the use of DARA VMP. But the key message is about the PFS, estimated now at a median of 36 months, with an overall survival advantage in favor of the quadruplet DARA VMP. And this is very important because, as you know, it's rather difficult these days to show overall survival differences in multiple myeloma. But the ALCYONE trial definitely confirmed that an antibody-based quadruplet treatment combined with bortezomib and an alkylating agent, RVMP, is a valid option. However, not all patients are able to receive these regimens, and one may wonder whether we can replace the bortezomib with an oral proteasome inhibitor such as ixazomib. And this is the phase 2 HOVON 143 study where Dr. Zsigman presented an interim analysis looking especially on the impact of fitness and frailty. And the conclusion from this work is about the feasibility actually and the relatively good results. Also, numbers are relatively small, 23 patients in each group, but definitely the frail or unfit patients are able to receive an effective treatment, including a monoclonal antibody. And if you don't want to use a proteasome inhibitor or an alkylating agent, in elderly patients, the alternative would be the combination of an antibody like daratumumab plus lenalidomide and dexamethasone. And this is the well-known, already published MAIA trial, which has been updated during ASH 2019. And again, we have good confirmation about 30% MRD negativity related to the use of DARA, lenalidomide, dexamethasone. And when you look to the PFS figures with a median follow-up of 3 years, actually the median is not reached yet in the DARA Lendex compared to Lendex. And this control arm Lendex is really behaving very well with almost 34 months of PFS. So clearly now it appears that using a daratumumab-based therapy in the elderly and non-transplant eligible patients should be part of the standard of care of these patients who are going to enjoy relatively long PFS, but also an overall survival advantage when you look into the updated ALCYONE results. Unfortunately, despite all the progress we have seen in the frontline setting, the majority of the patients will continue to relapse, and at some point they will become refractory. And during the ASH 2019 meeting, we had a late-breaking presentation about the first results of the so-called CANDOR study. This is a phase 3 randomized trial comparing a control arm with KD, carfilzomib, dexamethasone, as it has been validated in the ENDEAVOR trial and approved, versus actually carfilzomib dexamethasone combined with a monoclonal antibody against CD38, namely daratumumab. And the primary endpoint was PFS, and you can appreciate that the combination of daratumumab, carfilzomib, and dexamethasone is doing significantly better compared to the doublet KD, with an advantage in terms of response rate, but also in terms of achievement of MRD negativity. When we look into the median PFS, the KD doublet is around 16 months, 15.8, and this is not yet reached in the triplet daratumumab, carfilzomib, and dexamethasone. So definitely sort of almost 37% improvement, and this triplet based on KDD is going probably to make it rapidly into the routine practice, because we know very well that many of our patients are refractory or resistant to lenalidomide, and then one would like to design options that are IMiD-free or lenalidomide-free, and this combination of KDD appears to be highly effective. Another player in the relapse refractory setting is Selinexor, with a very unique and new mechanism of action. This drug has been approved some time ago, although there were some debates about its tolerance and especially toxicity when it comes to anorexia or fatigue or loss of weight. And actually, we had during ASH 2019 results of this phase 1b/2 study called the STOMP. And to make a long story short, actually through decreasing the dose of Selinexor and combining it with pomalidomide, actually it appears that the tolerance of the drug is much better. And I believe this drug will find its way in the later relapse settings or in the advanced line of therapy. Another novel and important drug which has been debated in the field of multiple myeloma is venetoclax. And you may remember that the Bellini randomized phase 3 trial was quite disappointing, because despite a better efficacy, there was increased mortality in the venetoclax arm when combined with bortezomib and dexamethasone compared to placebo, bortezomib, and dexamethasone. And this has led to the discontinuation of the use of venetoclax in myeloma. However, during the ASH 2019 meeting, we have seen very important and interesting data that, in my opinion, will rejuvenate the use of venetoclax in a specific subset of myeloma, namely the translocation 11-14. And we will have here the first specific targeted therapy, I would say, in multiple myeloma, further supporting the idea that multiple myeloma is not a unique disease, and at some point in the next few years, we will be able to dissect the myeloma disease into different entities, and one of them is this translocation 11-14, with some very good results when using venetoclax. Last but not least, we have seen an amazing number of studies related to the use of immunotherapy and cellular therapy, especially CAR T cells in relapse refractory myeloma. I'll start first by showing the update of the phase 1 LEGEND trial using the LCAR-B3BM construct from China. I would kindly remind you that the first results of the study were presented last year with a shorter follow-up. Now the follow-up is more than 2 years, and the results are well confirmed, and they are quite convincing, with a median PFS of 28 months in patients who could achieve a complete remission, and the overall PFS is almost 20 months. So clearly, with longer follow-up, the benefit of using this CAR construct directed against BCMA is proving to be effective in multiple myeloma. The CARTITUDE-1 trial is actually using the same construct of CAR T cells directed against BCMA, but this study was performed in a US-based population who have received a median number of 5 lines of therapy prior to CAR T cells. In the LEGEND trial that I have just mentioned, the median was 3 lines. And when you look into this figure, it's really amazing to see the level of response that can be achieved. And 100% of the 17 evaluable patients were able to achieve MRD negativity. And I would kindly draw your attention to these 9 patients achieving a level of 10-6. And this is extremely important in my opinion, because again, I believe that a 10-6 level of MRD negativity, although this is not the threshold adopted by the IMW group, such very deep threshold is really a good indicator of long-term response and survival. So definitely these anti-BCMA CAR T cells are going to make it quickly in the field of myeloma, and the safety appears to be relatively good, with very few numbers of CRS and neurotoxicity. And another important translational message is about the CAR T cell expansion in many of these patients. As you know, CAR T cells are a living drug, and one would like to see them persisting over the long term, because that may correlate with cure. So this is really work in progress. Also, actually, interestingly, in this CARTITUDE trial, the best responses were not necessarily dependent on the peak expansion. The other study that was not actually presented during ASH, but that was a press release that we have seen while we were at ASH, is about the phase 2 KarMMa study. And this is the study using the BB2121 construct that was, the first results were published in the New England Journal of Medicine a few months ago. And actually, this was the open label single arm study, which included 140 patients. And this phase 2 large study confirmed the results of the initial series, showing a median PFS in a very heavily pretreated population of almost 1 year, 11.3 months at this dose level. And another important message is about the relatively good safety, with a very low number of severe CRS or neurotoxicity. But the field of CAR T cells in multiple myeloma is moving very rapidly, and also we don't have yet any CAR T cell in myeloma approved. Different groups are already working on bispecific CAR T cells targeting two antigens, for example, BCMA, which is the most popular one, but also combined to CD38. And we had a presentation in a small group of patients who received a median of 3 to 4 prior regimens. And you can appreciate a lot of these patients were able to achieve a stringent CR, including MRD negativity. And this is a very interesting approach because it may help to avoid the relapse of the disease through an additional control targeting a second antigen like CD38. Last but not least, I would like to spend a few minutes about the use of bispecific antibodies combined with a T-cell engager. And I believe this product called CC93269 was clearly a major highlight of ASH 2019. This T-cell engager products bind to BCMA, similar, the same antigen used when manufacturing the CAR T cells, and it's actually a very attractive way of bringing the T cell into the plasma cell in vivo without any in vitro or whatever modification. And Dr. Costa presented this dose escalation study, which is summarized here. They have included 30 patients who have failed a median of 5 regimens prior to inclusion, going up to 13 regimens. You can see the details of the different drugs that were used. Interestingly, more than 90% were exposed or refractory, 76% to daratumumab or isatuximab, and actually 76% received an auto transplant, and 3 patients already underwent an allogeneic transplant. When it comes to safety, actually it is very interesting to observe a relatively very good safety profile. There were 4 cases of death in this heavily pretreated population. One of them was suspected to be a cytokine release syndrome related to the experimental drug. The other cases were not felt to be related to the drug. And interestingly, compared to the other bispecific antibody used in the field of hematology, namely blinatumomab, actually there were no significant neurotoxicity, which is extremely attractive in this population. And when you look into the response over time in these patients, actually 5 out of the 30 patients, 17%, achieved an MRD negative stringent CR and CR. And out of the 13 responding patients, 92% achieved MRD negativity. So these are really very impressive results that, in my opinion, can at some point challenge the use of CAR T cell, because obviously these are drugs that are immediately available off the shelf, and the safety profile and the practicality is very clear. So that was the summary of what I felt are the major highlights related to myeloma from ASH 2019. I believe this ASH 2019 will be remembered because this is where we have seen consolidated data about CAR-T cells, advent of the treatment of smoldering multiple myeloma, and most importantly, the introduction of bispecific antibodies and T-cell engagers, which are going to make a true difference. And it's not only about myeloma, it's also ongoing in non-Hodgkin lymphoma, where we have seen also a plenary presentation about a bispecific antibody and T-cell engager directed against CD20. With this, I'd like to thank you all for your attention wherever you are. I'd like to thank you for your loyalty to the IACH webinars, and I'm more than happy to take your questions. So we have already several questions. One of them is about MRD. As MRD is becoming so important and it includes PET-CT, do you believe we will need to biopsy leftover lesions similar like we do in lymphoma? This is a very difficult question. I fully agree with you that myeloma can be a patchy disease, and sometimes it's not enough to have MRD negativity by NGS or flow cytometry. This is why, actually, based on the Cassiopeia trial, there is no concordance between biological MRD and PET scan, and both tests are actually complementary. Also, I did not mention, but we had during ASH 2019 several presentations about the use of mass spectrometry for evaluation of the monoclonal component. And this is really very attractive because obviously you can easily perform this based on a blood test compared to the bone marrow aspirate. So we have really a lot of questions. I may not be able to go through all of them. So one question is, do we have data regarding toxicity of the KRd approach in smoldering multiple myeloma compared to the approaches using daratumumab or ixazomib monotherapy? Well, it's very difficult to compare these trials when it comes to results because the philosophy and the design of these studies are totally different. With the monotherapy studies, the idea is to give a mild, gentle, very safe therapy and to delay the progression of the disease. And in the CESAR trial, which has used KRd induction, autotransplant, and consolidation and maintenance, the idea is really to use a very heavy, strong treatment to try to eradicate the myeloma disease. In the CESAR trial, but also in the other trials, the safety appears to be very good, and I agree that a safety issue is an important question when it comes to treating smoldering multiple myeloma, because these are, in theory, patients for whom we do not propose a therapy today, but the different studies, including the randomized trial from ECOG published in JCO earlier this year, are probably now pushing towards introducing therapy earlier in these patients and not wait until organ dysfunction. what is the effects of the new antibodies and or CAR-T cells in plasma cell leukemia? Definitely antibodies can play a role in plasma cell leukemia, and actually we know that the process of plasma cell leukemia is very bad. We had a presentation from the Hoven group during ASH 2019 about 15 patients with plasma cell leukemia who received KRD, for instance, but definitely adding a monoclonal antibody is, in my opinion, a feasible approach. I didn't see studies looking into CAR-T cells with plasma cell leukemia. So we have many questions about maintenance, and for example, is daratumumab maintenance can replace lenalidomide maintenance? We don't have the answer for this question, and I believe the question is after transplant. Obviously, this can be compared to the situation of follicular lymphoma as it has been done with rituximab, but I believe we really need to wait for the randomized trial. For the time being, I think the approved drug and the standard of care is lenalidomide. My best guess is that by combining two highly effective and safe drugs, we can further upgrade the response and hopefully achieve a cure in these patients. We have also, I have a question here. What is the role of allotransplant with all of these new therapies? Well, this is a very difficult question, actually. The role of allo has never been settled in the field of multiple myeloma. We had during ASH the results of a meta-analysis looking into different allo trials, and I think the message from this meta-analysis presented during ASH 2019 was that although they were relatively old studies, still there is an advantage in terms of PFS, but there is no overall survival advantage. Well, there are still dozens and dozens of questions. I think for the sake of time, we will have to close the webinar. Please do not hesitate to send me your questions by email. I'll be more than happy to answer it. Thank you again for joining us for this webinar. And wherever you are, please have a good day, a good evening, or a good night. Thank you very much.